We'd love to continue this great dialogue by now bringing up our panel. So I'm going to first introduce the moderator of the panel, AKA my boss. So Cynthia Carmona is the Director of Government and External Affairs for the Community Clinic Association of Los Angeles County. And like Monica stated earlier, we represent 53 community clinics and health centers throughout LA County, most of which are federally qualified health centers. And they operate over 200 clinical sites throughout the county, and a lot of them do have dental co-located there. And so Cynthia actually, in her role, oversees and conducts the development, implementation, and evaluation of our association's advocacy and government and public relations activities. Prior to joining CCLAC in 2008, Cynthia was a state legislative analyst on health issues for the California Public Employees Retirement System and the Managed Risk Medical Insurance Board, where she monitored SCHIP reauthorization and other state legislation. So please join me in welcoming Cynthia to the stage.
Thank you. So how wonderful was Dr. Brown's presentation? Every time I hear her speak, I'm wowed by a couple of new things that she has. And so, which is just amazing that she's been 10 years doing this, right? And we're still kind of having a tough time getting along. So let me introduce the rest of the panel, because we're going to talk a little bit about why we're kind of trudging along and what are the barriers we need to address. So first we have prenatal CPSP educator Magdalena Estrada. She could please come up. Thank you. We also have dental director Rosa Arzu. Rosa, could you please come up? Thank you. And then we have a prenatal provider, Dr. Nathana Lurvy. Hi, doctor. And then another private dental provider, Dr. Shabanzadeh. Thank you, David. So we tried to get a good mix of folks who could come up here and speak to the different challenges and barriers that they're experiencing to increasing oral health care to this subset of the population, pregnant women. I know that just over the time we've been doing this work with MCH Access, we've experienced how difficult this can be. And so what I'd like to do to start off with is if everybody could kind of go down the line, mention kind of what kind of environment they're practicing in, what kind of population you're serving, and what percentage of pregnant women roughly you're seeing.
Okay, good morning, everybody. I'm a prenatal educator for Eisner Pediatric and Family Medical Center. And so we're right in downtown LA. The population we serve is mainly Hispanic. A big portion of the population is new immigrant, and most are under the medical program. As a health educator, I mainly see women for prenatal education for classes. I'm extremely lucky to work in a health center that also has dental in the same building.
Hi, I'm Dr. Nathana Lurvy. I'm an OBGYN. I've been practicing in Inglewood for a dozen years, and the practice is currently a part of a multi-site FQHC, South Bay Family Healthcare Center. Our site is exclusively women and now children, but the FQHC does have dental care available off-site. About 30% of the patients that we see are African American. The remainder are mostly Hispanic with a scattering of other diverse backgrounds. Many of our patients are eligible for Medi-Cal. Some of them are completely uninsured, as is the FQHC mission. We do have some cash patients and some private patients. And it's a very diverse population. The vast majority of them do have some English-speaking capability, but there are certainly patients that are more comfortable in other languages, including Urdu and some other, not just Spanish as a second language. And then we see a lot of teens, because one of the sites that we have is a school-based clinic site. And so those teens do get referred up. And referrals and reimbursement are under the FQHC system, which is unique and different from many of other people's reimbursement systems. But I have in the past practiced in that same community as a private practice. So I do understand the difficulties of trying to get reimbursed under straight Medi-Cal.
Good morning. I'm Dr. David Shabanzadeh. I'm a practicing general practitioner with emphasis on pediatrics and as of 5 years ago with pregnant women specifically. I work with a number of clinics in the area, and the majority of the problems that I do see associated with it, as Dr. Brown says to us very eloquently, it's lack of education. A lot of issues are coming with younger women being pregnant and being unable to attend or not understanding what is involved during pregnancy and how the oral health is very, very important as far as that. In our office, we mainly focus on interviewing them, education, education, education. We introduce them to WIC programs. We emphasize and basically pressure them into going into there and try to use the benefits, and also go on their website and attend their lectures and attend their classes in order to get somewhat familiar with what process they're going to. And my main focus group is actually young ladies from the age of 14 up to 19. I have a very large immigrant population that I see. I would say about 40% of my patients are immigrants, and unfortunately a lot of them lack the speaking the English as a first language. So we do implement a lot of Spanish programs, including pamphlets and such. Something that Dr. Brown had mentioned as far as types of practitioners that can refer to dentists. My experience has been that a number of OBGYNs actually use NPs as a part of a practice in order to see a large number of the patients. So I think by pushing that type of education into the NP program, either at the school level or just with the OBGs discussing that with their staff, that would be a very important issue going through, an important way of introducing this whole into the program.
Good morning, ambassadors of perinatal oral care. My name is Rosa Arzu, and I'm the dental director for Ultimate, but I also practice at the Bell facility. We are a medical, dental, health, seniors also combined, and most of our clinics do have dental, but there are some that don't. I'm sorry, I thought you were talking to me. I'm not going to repeat what the panelists have said. Some of the barriers, in addition to those that we have seen, is that we need to make sure that everybody understands why we're doing this, starting from the front office, back office, even medical providers. I did had an OB provider ask me, what is SRPs? So we have to make sure that they understand what is that we're asking for and why is it that we need to do it. Also, some assistants that didn't understand why we're taking x-rays, and when they were taking x-rays, they were advising the patients not to do the x-rays. So we have to make sure that we're all comfortable, that we're all educated on the importance and on the safety for our patients. One of the initiatives that we have is called our oral health unit, and it's actually based of a provider, an assistant, and they go to the medical clinics where we don't have dental to pretty much educate the whole team, medical assistants, the medical providers, and have that opportunity to see the OB patients, as we know that transportation is one of the biggest barriers. And also, we do see a diverse population. So I come from Guatemala, so I understand that the culture is every time I'm pregnant, I'm going to lose a tooth. So that's pretty normal. It's part of what they know, and pretty much there's nothing you can do. So really changing the culture and having the opportunity to be the ambassadors to educate these pregnant patients and give them the opportunity to get this treatment by finding them the closest dental home that is close to them. Our barrier also has been the release form, so you have to make sure that it's easy, straightforward for the medical providers, because their cycle time is important, so we want to make sure it's something adequate to the workflow, and always consider for any upgrades, you have to constantly checking that the release form is available for them, so that it's something that the initial of the visit, they are going to clear it and send it to the providers, as it still is a concern for the dental providers. So we have to work along making it an easier process and accessible for our patients. Thank you.
Great. So I want to thank you guys for kind of diving into the barriers, because we're going to do a little bit more of that now. I think that we should probably start with the referral process, right? And so what we find and what I've found in our work is that it's really different everywhere you go, how the patient's actually getting to the dental chair. So could you folks talk, and you've already talked a little bit about it, but what does the referral process look like in your setting? How are you making that work? And what kind of barriers did you have to overcome to get there in the referral process specifically?
I think we have gone through everything Dr. Brown mentioned earlier. First, getting to the form, being sure we have a referral form that was signed by a provider. So in our case, the referral form had to be signed by a medical provider. So as an educator, the process for me was to tell the patients, please be sure you ask for your provider's form so you can take it to the dental department. So that's been the practice, getting that referral form from the provider and then going to actually get the appointment to see the dentist. Now, that's been the history for us. However, in the last weeks, we got together and trying to utilize more the CPSP program. And so incorporating more the referrals now, initiating them by the CPHWs. So it was a really good agreement trying to get that form now initiated by the CPHW. So it's a lot, it will be because we're in the process of implementation. It's not completely done now, but in the process, the CPHW's comprehensive prenatal health workers will be able to refer the client directly for the appointment with the provider. So that will speed up all the process.
Great.
I'm going to take back some of Dr. Brown's suggestions. So I think it's going to change, but our current setting is to only have the referral be done when there is an identified problem. So it's not a standard part of, I hand you the prenatal vitamins, I hand you the referral to the dentist. But if there is an identified problem, we have a pre-printed form, so it doesn't take very much provider time, and hand that to the patient. We have internal dentists in the FQHC, but they are very busy because they are taking care of all the patient population in the FQHC, not just my pregnant patients. And so the patients have to get in line. And we also can send them to community providers. The community providers will, as all the barriers that we've mentioned, will sometimes accept them for care, will sometimes accept them for only limited care, will sometimes refuse to initiate a process of care that is likely to take longer than the pregnancy and the postpartum period. So the patients tend to have no problem getting extractions done. If they have anything beyond an extraction that may require months of care and may stretch beyond their presumptive eligibility and their pregnancy and emergency care situation, then the community dentists are reluctant to touch them. And I have a great deal of problem getting the patients taken care of. I've even referred patients down to USC to the dental school to try to get them care, which has worked, but it is quite a lengthy and arduous process. And so the patients really are back of the line. Some emergency rooms do have dental care available through the emergency room. I've referred folks to Harbor UCLA for that. But you can't just refer them to any emergency room because sometimes you'll send them to any emergency room and they don't get care at all.
Right.
So, and I am, like I said, I've been in the same community for a dozen years. I had a private practice there previously before it became an FQHC. I know a lot of people both inside the community clinic setting and outside the community setting, but even with all those contacts, it is still very hard to get people appropriate, timely care. And it has been mentioned that they will often just get antibiotics from the dentist. At this point, I just give them the antibiotics and then say, go make the dental appointment. At least you'll feel a little bit better while you're waiting for the dentist to tell you that they won't take care of you. I'm coming here hoping to get a lot of tools to get back because I don't have great solutions.
Dr. Louvie, can I just follow up with a couple of questions?
Yes.
So you're referring folks when you see there's maybe a problem. So if they're complaining about tooth pain potentially, that's when you'll actually refer them? Is that how that works?
So one of the issues for OB right now that's been a really big push in the state of California is to deal with problems of preeclampsia and hypertension in pregnancy.
Okay.
And so folks will often complain of headaches, and if they complain of even a little headache, we jump all over them. And because I don't want the consequences of labeling people as having preeclampsia are quite significant for their timing of delivery because of recent recommendations that are going to uniformly lead to early delivery of those babies in early term rather than full term. So we want to make sure that there's no other source of that headache that I can pinpoint. Some of my folks will have chronic hypertension. They start to complain of a superimposed headache. Now I'm worried that they've got atypical preeclampsia. Even if the labs are normal, they're going to get delivered earlier than they should. I want to make sure there's nothing else causing that headache. I want them to get their eyes checked, which luckily I have optometry down the hall and they love me, so they'll see the patients. But I also want them to get their teeth checked. And so that is a main reason for sending folks. And anybody who complains of dental pain gets sent. And as has been previously mentioned, a lot of folks do have untreated dental problems that now when they are pregnant, they're coming into care maybe for the first time since their last pregnancy, maybe for the first time ever. And that is a reason to send folks. But we do not routinely send folks just for cleaning, and part of that is because they get turned away.
Right. And so you mentioned you're also sending them out to other community providers. So is that based on your dental department, their next available appointments too far out?
That
Okay.
is based on the fact that the FQHC has chairs, but those chairs are going to be used for all of the patients from our 5 different clinics coming in with whatever problems they have. And you need to have a new appointment to get the patient in if she hasn't been seen before. So your existing and follow-up appointments are taking up some of those appointment slots. And we also tragically transitioned to an EMR, which is still giving us trouble and has cut down on our productivity. So I don't know if that is a uniform problem or if some of you guys have moved past that stage where it's cutting down on your productivity. But it does cut down on the productivity quite a bit in our experience. We're still in that early stage. And so I just, there's not capacity to, if I were to take all of my 50 new OBs a month and send them all for a cleaning as soon as they are taken in by CPSP, there'd be no slots available for any of the other patients in the FQHC.
So the capacity question. Okay, Dr. Shabanzadeh?
The biggest issue, the biggest issue I see is not the referrals. It's unfortunately the patients don't use those referrals. We see the same type of problem for postpartum. We basically set schedules for every single pregnant patients we see for a postpartum appointment approximately 2 weeks after the 40-week due date. And we call them, we send them letters. Unfortunately, maybe 1 out of 20 shows up. And that's an issue that's been facing a lot of times. The other issue is just basically cultural. Everybody believes that x-rays and exams and dentistry during the period of pregnancy is absolutely a heresy. Doesn't matter if their doctor tells them or not, the only reason they do come in is because of a bad toothache, which is unfortunately at that point we can't do it that much. I don't want to say anything bad about Medi-Cal, but unfortunately we're very confused. I've been in contact with their operators, the dental operators. If I do have an open-end med, I know they have a code 3220 for pulpotomy and 3221 for debridement. However, I don't know if that can be followed up by a root canal. I've been through the forms, and that's one of the reasons patients don't want it and just basically, lack of a better term, want it yanked. But again, we're still being associated with pain. We're not associated with pregnancy, and that's one of the biggest obstacles I've seen in practice, being in there for about 21 years and specifically doing pregnancy before pregnant patients for the past 5 years. So it's just a lack of cooperation between the medical doctors, the dental offices, I believe, but the patients themselves can be blamed as well because they don't want to seek that treatment. They just think it's something they can just forget about. So I think that's one of the biggest issues we're having. As far as I think that's the basic referral portion. Is there any other questions?
Oh, we've got more. Yeah, sure. I wanted to let Dr. Arzu speak to the question.
So for our referral process, we have electronic records, EMR and EDR, which is the electronic dental records. At this moment, there is some integration, but it's not fully, so that is a barrier. We requested that on the medical records, there is currently a pop-up for all those pregnant patients so that the referral form appears and they can automatically complete it and save it on the system. The only challenge is if they click the X and they don't fill it out, then we won't have anything in writing. So pretty much dental providers go to the medical records and verify that there is a referral form, a release form, and that they're able to confirm that it can take x-rays and start with the cleaning. Another barrier continues to be education because patients are still concerned about the x-rays and also the type of anesthesia, if that will affect their babies. And there's still some education with medical providers regarding the procedures that we're doing, if they're giving a release, are they going to be liable if anything happens to the patients. One of the things that we just learned is that with the upgrade, we have to consistently evaluate if there has been any changes. We didn't know that currently the pop-up wasn't working, so you constantly have to be reviewing the process to make sure that everything is flowing. You have to make sure also on your schedule for the referrals that there is access, because then providers get disincentivized to refer the patients if you're not offering an appointment immediately.
Thank you. I'm just wondering on the referral piece to outside providers, if the fact that the dental service is not within the clinic is also impacting the number of folks that follow up on those referrals.
So, as I mentioned, we're a multi-site clinic, so referral to a community provider that's down the street is actually easier for the patient than referral to someone within our own system that is slightly more distant. So I think community providers are a great resource, and that there should be this barrier between, inside my clinic, outside my clinic. You need to get the patient into the quickest way that they can get the care that they need. And it's all going to get paid by Medi-Cal in one or another weird version. So they should be able to access outside.
Great. And that's a great segue, because the next thing I want to talk about is reimbursement. And Dr. Lervay, you kind of mentioned the hesitancy of some providers to take on those patients with more long-term implications, because it seemed like the coverage piece was important there. So maybe we could start with you, Magdalena, and we could just talk a little bit about any reimbursement challenges that you guys are seeing when it comes to providing dental services to that population.
Well, I am not directly in the dental department. We have different departments at Eisner. But speaking with the manager, one of the things that I was told was that it is absolutely all the codes have been identified, so it's been easier to do billing for us. So I think that I really put that a lot into the billing department, because they have been able to manage that. So we haven't had really any issues.
Right.
We used to have patients being sort of turned away when they only had PE, the percent of eligibility, but that was been totally clarified. And so all clients are seeing, and we have not that I know any problems with reimbursement.
Great.
Identical.
Yeah, and I know that just this year I have had some folks confused that in the FQHC setting, that dental and primary care visits on the same day were not reimbursable, but it is actually, we've been trying to make it clear with our members that FQHCs can actually get reimbursed for both the dental visit and the primary care visit on the same day, which is separate than the mental health care side, but just wanted to clarify that.
Thanks.
Dr. Lervy?
So as an FQHC, we get paid per visit, and that is a unique situation that just lets us run through volume, and we haven't had trouble with that. Our trouble is with some of the folks that truly can't be linked, or how much underinsured people we're going to be taking care of. We also have had people flowing with the Affordable Care Act. Some of our patients have been flowing into other types of insurance products, which are not going to be paid at the FQHC visit rate, and that has been very confusing, both for the medical and the dental side. And I know everybody's probably struggling with the same, and depending on which percentage of your folks are now picking up other insurance or transferring care and trying to figure out if they can stay with you as their provider. So we have not figured that piece out as people move away from straight Medi-Cal and may be eligible to buy other things. That's still an open question.
And you're speaking about exchange health plans specifically?
Yes.
I would say on the dentistry side, as far as billing, there's always been problems associated with billings, specifically with PE, as you mentioned. A couple years ago, it used to be much worse because it kept getting lost for some reason in the system. As of lately, it's become much, much better. The only issue that our office, and I know a large number of other offices serving the pregnant community faces, is billing and rebilling and sending claim inquiry forms indicating patient is pregnant or patient is postpartum. I have a basically 99% electronic office, and we basically use MDON for everything. And although it says on the paperwork that the patient is either pregnant or they're such amount of such amount of time postpartum, we still get that the refusal of payment basically, and indicating that we have to send CIF forms. The other issues we're facing is non-signatures on emergency forms, which we're very confused when we're sending electronically. Am I supposed to sign it twice? So we have to send CIF forms on that. The biggest issue I would say is as far as periodontal scaling and route planning is we're getting a lot of denials on that, basically saying that you can't see either calculus on the x-rays, there are not enough radiographs, or the radiographs haven't been attached. The infamous code 081 for the people that know what that means. And I've spoken to a number of dental operators, and unfortunately, they basically regurgitate what the code is, and I can see the code right in the book and what it says, but I don't know how else to implement it. I put the crestal bone loss in there, periodontal attachment is there. We've even attached photos showing a lot of inflammation, and again, it has been declined. So it's a very, very confusing process for us to get reimbursed. And I know, as a matter of fact, 2 dentists that used to see a lot of pregnant patients, and they absolutely refuse to do so because of these factors. As far as the other insurances that we work with, as she mentioned, all of a sudden, a lot of people that used to have Medi-Cal have been, the people that had Medi-Cal are now transferred to Access Dental or Liberty Dental, and a lot of us have no idea how that's working. So it's a very, I think it's a compounding problem that keeps going on, growing and growing and growing, and hopefully once this whole situation with healthcare gets clearer, then we can go through that. But I think that's pretty much the gist of it.
Okay. And Dr. Arson?
So for us, one of the biggest concerns that we see on the medical clinics that we don't have dental is that education is not billable. So sustainability, if we only want to focus on OB patients, it's not sustainable program. So as I mentioned, the oral health unit is actually a provider with dental assistants that are going to the medical sites. And whenever the medical provider is running behind, they get some time to educate these pregnant patients or even infants of anticipatory guidance or the importance about getting dental care. And if they don't know about benefits, referring them with somebody that could assist them on getting more knowledge and seeing if they're eligible for the medical benefits. So that has been one of the barriers, because pretty much you do a visual exam, education, and you're doing a caries risk assessment, but you can't really focus only on OB. So there is a limited number of OB patients that you will be focusing on.
Okay. So I think right now we want to move to the Q&A period in our audience. So are there folks out there who have questions for our experienced panelists? I see one in the back over there.
I know that you mentioned that educational classes were not covered through the dental piece, but my question is for the prenatal worker for CPSP. Through the program, do you provide any kind of classes or educational workshops with your perinatals about dental care?
Yes,
Is
we
that
do.
billable?
It is under the CPSP program, the health education, individual or group education. I don't know, Katie's here. She's like, yeah. So we do incorporate dental education in different topics, not just specific on in a dental class, but we also incorporate it into preventing premature labor, healthy pregnancy, nutrition, and baby care and infant feeding. So there are basically little pieces that are covering the entire subject. And in addition to that, yes, we do have an OHI class in the dental department, specifically in the dental department for all the pregnant moms that are referred. And absolutely, we are able to bill under CPSP.
Thank you.
Any other questions out there? Oh, I see one over there. Dr. Cabezas. And could you guys all please remember to introduce yourself
Hi, my name is Maritza. I have a question regarding the referral. So if a patient just walk in and want to have dental care, since they are not getting prenatal care from your clinic, they won't have a referral form. Can they get dental care, or they would have to go to the prenatal first?
In our case at Eisner, the patient can get an appointment, and there is a form that is provided to the patient. So the patient can get that type of medical history, medical information from the OB.
So they would have to go to the Eisner
won't.
OB first.
Not to the, well, if it is an Eisner patient, we have different routes to refer the patient to the dental.
but if they
But
just-
if it is a non-Eisner patient, the patient can still come, get an appointment for dental care. But if there is no medical information, there is a form that is given to the patient herself. So she can take that form
Like
to
a
the
his-
OB provider.
medical
And
history.
is that necessary to be seen, that
It
form?
is not, it is recommended and they need it at this point. They do need it because they do want to have the history of the patient. Not to, they don't deny the service in the department. The patient can be seen, but they do want to have that history. Does that make sense? It's like,
But
still they need the form.
history that they provide, or they still
No,
have
the
to-
history from the OB provider.
Okay, so they have to go to, okay, got it.
Yes, that is, yeah, it is a barrier. So I don't know if you wanted to mention anything about.
And the guts.
Mina Habibian from USC. I've got a question, well, a couple of questions from Dr. Lurvy. First of all, how often and how many times a pregnant woman visit the OB? Number one. And number two, is the oral health issue kind of addressed? Does the OB ask the patients about their, oral health during these visits, or anyone in, the staff level kind of talk about oral health with the patients?
So obstetrical care is provided in the Medicaid population in a number of different models. And as was mentioned, many of the OBs in the non-FQHC community that are seeing Medicaid patients are working with mid-level providers in the office. So most of the OB visits will be with a mid-level provider until the end of the pregnancy. And then they'll see the obstetrician who will be doing the delivery. That's one model. There are other models under an FQHC environment where your reimbursement per visit is a little bit higher. You may be able to see a physician more often during the pregnancy. The basic schedule of prenatal visits is going to be about 12 visits, assuming people start early in the pregnancy and follow the ACOG schedule. But that's very dependent upon when people initiate prenatal care. And even though 86% will, in California or whatever the number that was up there, initiate in the first trimester, that doesn't mean they're necessarily seeing a physician in the first trimester. They may come in for an initial intake visit. And then it also depends on how often people come. In my patient base, historically, folks may lose their Medicaid on the first of the month. So we may not be able to see them on their scheduled appointments, and they drop out for a couple of months while they've lost their Medi-Cal and go get it fixed and then come back in. Alternatively, some of the patients that I see have a little bit more social instability. Their housing may change during the pregnancy, or their relationship with their significant other may change, so they move from place to place. So I have a number of patients who may see me initially, then they end up in the Antelope Valley. Housing is less expensive. Then they come back because they want to deliver in LA. And that's actually not my unique observation. I've spoken with folks up in Sacramento who were puzzled because the mother's zip code was out in the Lancaster area, but the zip code for delivery was in the central LA area. And they were like, why is this happening? They'd even noticed that at the state level. And that's because women are moving back and forth. And they want to deliver in a hospital they feel comfortable with, where they feel that they'll be welcomed, and there may be language or cultural issues, but the housing is so much cheaper once they get out of the central part of the city. And that's where they want to raise their growing families, or that's where their boyfriend has a job. So there's all different things that go on. So there's not a set number of visits that I can tell you is what everybody gets, but it's going to be a large number. So there certainly should be an opportunity to discuss oral health. That being said, my personal experience over the last 20 years in a variety of different practice settings in Los Angeles is oral health is not at the top of the list of things that we feel we need to give our attention to. And there'll be pushes at different times to incorporate things that are not medical model into the obstetrical care. For example, screening for domestic violence, talking to folks about mental health and screening for perinatal depression. There'll be pushes to do anticipatory guidance about timing of delivery. For example, MCHA Dimes has done a big push to talk to women about what is term pregnancy. Don't try to get yourself delivered early. You want a full 9 months, and don't ask to be induced because you're tired of being pregnant. So there's a lot of different things that are taking people's attention, and oral health has not been at the top of the list. On the forms that everybody's supposed to do for initial prenatal visit, there is an ATENT, but it isn't specifically to say, how are your teeth? And do you have pain with eating? That's not something that either a nurse practitioner doing the screening or an obstetrician doing the screening is going to directly address. Now, that may be something that we ought to think about differently, but that's the current state based on a number of different settings.
In your opinion, is it because of the lack of time, because there are lots of procedures that needs to be done during the visit, or is it more of a lack of education?
I think there's a lot of different potential reasons. I haven't surveyed people to say why they don't do it. But again, as I mentioned, people will periodically make pushes to add things on, such as mental health screening or domestic violence issues or anticipatory guidance about breastfeeding or pushing to talk to folks about contraception. There begins to be a lot of non-medical education that you're trying to squeeze into the visit. And in order to make a Medi-Cal obstetrical practice work economically in a non-FQHC environment, you need to be seeing at least 30 people a day. Mm-hmm. So I want you to put that in your head. That's why my practice got sold and turned into an FQHC. But 30 people a day is a very short visit time. And now the more things you add into the visit, the less likely any of them are going to get addressed. You can put them into group education, as is a wonderful thing from CPSP, but then if you put them into the group education, they're not individualized, and you may not have the same safe space. We are starting in my practice, we've been working with UCLA to be able to get centering parenting and centering pregnancy, which hopefully will allow 2-hour-long visits for the majority of the time in the pregnancy, and will be more of an opportunity to bring in those educational pieces. But under the current model, even in an FQHC, you're paid per visit. So the more visits you can get through, the more money you make. The more money you make, the more services you can provide. It's not just about greed, but you may want to shift some of those dollars to your totally uninsured patients or the people you don't get reimbursed for at all. But the more you shorten the visit by focusing on the volume, the less you can fit into each visit.
Great. Thank you, Dr. Lurvy. I think we had a question over here.
Hi, my name is Shirley King. I'm an assistant professor at Western University. I have a question for Dr. Lurvy. I've spoken to a couple of OB/GYNs who've said that even though the standard care now we know is the dental treatment should be provided at all time, when it's closer to term, maybe like 33 weeks, 35 weeks, 36 weeks, they don't want any stressful, quote unquote, stressful treatment being done, such as extractions or root canals, not to possibly get the mother into being induced into labor. What's your opinion about that?
Their opinion is not evidence-based. There's a lot of things that people are hesitant to do, and the obstetrical community isn't any better than any other medical community about promulgating evidence-based practices in a shorter period of time. Although, as a community, obstetricians are exquisitely sensitive to risk of litigation. So, and any medical community is pretty sensitive to carrots, like reimbursement. So if there was a standard that said we will not reimburse you for prenatal care if your patient doesn't get seen during the pregnancy for dental care, the dental care utilization would go up. But we saw the same thing, for example, with preventing elective premature deliveries before 39 weeks. And there's good data that even though since the 1970s our professional educational folks had said don't induce people before 39 weeks unless you have something wrong, people were inducing before 39 weeks in response to their patients. And MCHA Dimes did a big project, and just encouraging people to change their practice didn't help. You had to put in what was called a hard stop, where you said you just can't do that. So putting in a hard stop for a positive action, which would be referring for dental care, is harder than putting in a hard stop to stop a negative thing. But people practice what they're comfortable with or what they were told they should do. Anecdotally, if they had one patient who went for a dental cleaning and then she had a problem, it's very hard to change the message.
I have another question. I apologize.
I could interject into that. As a person that sees pregnant patients repeatedly every single day, during that last trimester, we've always been taught, okay, the first period of the third trimester is safe to work. However, during the last month, basically never touch the patient. It's not just a matter of education, it's a matter of personal comfort setting. If I do receive those patients, I'm the first one to admit I don't feel comfortable. I go one wrong thing and I can induce. So automatically, if they do have pain, I send them to a hospital facility that's able to do an extraction or do care, or we basically place them on antibiotics. We speak to their OBG in that regards. But again, you have to get over that factor and the safety issue that whether if we treat this patient, we're doing more harm than doing good. So that question is always there, but at the end, it's basically a comfort level and what psychological factors that dentist feels comfortable with. So personally, I feel comfortable anywhere from first trimester all the way down to third trimester. But again, I can't force myself to see those patients in a situation that I have to do extractions or anything that's very stressful to that patient because of that fear that this might induce or this can harm the baby as well as the mother. So I don't know if that confusion can be proven scientifically somehow or not. It's just a matter of the comfort of the practitioner.
Sorry, I have one more question. I know we're talking about prenatal care, but I know also the care continues up, I think, 6 weeks after the mother delivers. Instead of only giving the OB/GYNs the avenue to introduce dental care, do we have any information to the pediatric departments where they're seeing the mothers and the babies at such an early age, starting from a few days to 2 weeks and on forth, to educate the mothers that the child's oral health care is in their hands, and that if the mothers get their dental care taken care of, that it will increase the chances of these infants and toddlers not getting cavities.
So,
I'm sorry. Again, one of the biggest issues we have is postpartum. One of the biggest issues we have is postpartum care. Patients are very hesitant to come in for the postpartum period, and I have no idea why. During the initial visits that we do see with the pregnant patients for the first visit or the second visit, I spend about anywhere from 15 to 30 minutes going over their medical history. If they haven't mentioned something to their OBG or their medical doctor or their NP, I basically force them to do it because I know a large number of the population has diabetes gestational, or they come from a family with either mother or grandmother that has diabetes, but they've never mentioned that to their medical doctor. So that's something we mentioned. We mentioned also you have to change the toothbrushes once a month. I have patients that have kept their toothbrushes for 5 years and they still haven't tossed away. There are patients that are still using Listerine thinking, oh, it's a very, very safe project. We inform them, do not use Listerine during pregnancy or postpartum because there is alcohol in it and there is some levels of absorption. So education is everything, but then again, when the post-op care is not there, you can't emphasize it. The other thing that I see in the practice consistently is pregnant mothers basically stuff themselves with Cheetos and every other thing that you can mention. And I was talking to the doctor earlier, under the WIC program, it's a wonderful program, but I don't know how the financing is done. They get $10 for fruits and then get anywhere from $5 to $10 to get juices, and not natural juices. These are juices full of sugar, which never made sense to me. And I spoke to a couple of WIC people that are close to my area, and they said that's just what's mandated and that's what's financed for. So again, something needs to change. Unfortunately, there is no education as far as what to eat. WIC is a wonderful program. They put the nutritional classes in there, but then again, they can't supplement it with a good nutritional program in some senses because of all the sugar that I see. And again, culturally, there's a lot of different levels. The type of food they eat, a lot of the food with the community that I'm in, it's mostly Salvadoran. It's very fatty, which is pretty much contraindicated during pregnancy, but that's what they eat. Unfortunately, what I see with a lot of women, oh, my doctor told me to drink a lot of liquids during the thing, and their version of liquid is soda and orange soda and everything else. So I have a ton of patients that think of soda as liquid to drink and basically go through pregnancy with that. So education, education, education is what you have to go through. And I think no matter what we do, I'm very lucky to work with a number of obstetricians, and they provide all the information that's in pamphlets. And I completely understand what she's saying because you only have a short amount of time to see the patient. But again, a large number of the patients in the community never reads those pamphlets. They basically collect it, they put it on the side and never look at it. I also work with the Southeastern Asian community a lot, and I notice they have a lot of fish in their diets, which again, they're not well informed. Okay, some types of fish have mercury and some other types are. I know they're in the pamphlets that the doctor gives because I work with the doctor and I've seen his pamphlets, but nobody follows it. So those are the issues that we have to basically shift some responsibility over to the patients and not the doctors because that's a factor that exists.
And did we see some changes to WIC recently? Those food guidelines, Lucy or Lynn, you want to clarify what those have been?
Changed in like October of 2012, 2010. So there isn't as much juice available in the packet. So, was there another response?
Well, the question actually was asking about pediatricians, which I don't know if that got answered yet. And my first answer is, as difficult as the economics are for running an OB Medi-Cal-based practice, it's worse if you're a pediatrician. And so their volume is even higher. And so their time is even more limited. They are already being tasked to screen for perinatal depression to add on to that. And my understanding from the pediatricians I work with is they're uncomfortable with that. You know, they didn't go into pediatrics because they wanted to deal with adults. And they're not comfortable with the kind of motivational interviewing that's needed to get adults to change their habits, because it's a whole different approach than anticipatory guidance for parenting, to talk to an adult with an established habit to say, how do you change this?
Great. I would like just to add that also we need to be sensitive that postpartum is even harder for OB patients to come into the clinic, either because if they had C-section, they're breastfeeding, they don't have a babysitter, and the infants are so delicate that they're hesitant on even thinking about themselves. So we really need to really make sure that we're making a good call by not treating the patients and telling them, I'll see you until you have your baby, because we're just setting them for failure.
I just want to add in regards to the pediatric that we do, what we are doing in the pediatric area is we are getting a dental assistant visiting daily to really find those babies and give information to the moms. So it's just like a brief time in between being seen by the provider, by the pediatrician, the dental information is given as well. And adding to that is, I think it's very important to recognize there are lots of barriers. And as a health educator, I think we really tend to blame the victim, which is the patient. And most of them have difficulty, and of course it's the culture, it's information. But the way that we are addressing the issues, if we can get more toothbrushes, or we can really provide that information, create the access to care, I think that's the answer, is understanding the culture, understanding the food, understanding the concepts that we have of the myths, but it's really addressing the barriers. There are way too many barriers for the community to get access to dental care. And one of the first things is that most clients do not know the Medi-Cal covers for that dental visit. And nobody wants, of course, has no money to pay for that dental visit. Just clarifying that it's covered by Medi-Cal and where to go, that alone can really help clients to look for that access.
Okay, do we have another question? Lucy?
Hi, my name is Lucy Quatinella. I'm a lawyer and a consumer health policy advocate. This conversation is so rich. I have so many questions. I'm going to limit myself, however, to one for now. Dovetailing on the last comment about Medi-Cal being available during pregnancy, even during this phase when the adult dental benefit was eliminated. And the big challenges we've all faced in working with consumers as well as providers to get that message across. Medi-Cal is there for pregnant women. And we're very fortunate in California. As was noted earlier today, many states don't have any dental benefits for their adults, not even their pregnant women. So acknowledging what a great job our state Department of Healthcare Services has done to make this happen. The flip side of it is that pregnant women don't have the full range of adult dental benefits. When we used to have Medi-Cal for adults and we're getting a partial restoration, the benefits that the pregnant women get are lesser than the adults used to get and that they'll get in the restoration. So I'm just wondering if any of the panelists could talk about how difficult it is with these conflicting messages. They're covered for some things, they're not covered for other things. So the fact that they're not covered from other things impedes your ability to treat. It creates an access barrier, and it also makes it much more difficult to deliver the message that some things are covered.
As a dentist, as I indicated, I'm going to tell you what my frustration is. They cover for a temporary filling, yet they don't cover for a regular filling. Temporary filling is made to last anywhere from 1 to 3 months. They cover for sensitivity medication, which I have no idea what that has to do during pregnancy. Okay, there are sensitive toothpaste, which work pretty much as well. They cover for pulpotomy, but they don't cover for a full root canal, which I've been practicing for 21 years. I have pretty much I've performed 50 pulpotomies in that period. And I mean, with kids I do it consistently, but for adults, and I have not seen any surveys done whether the pulpotomy is going to do the same type of healing as a full root canal does. So I don't know who writes the policies, because I've seen the same thing with the Access Dental with pediatrics. They cover $5 for one surface filling, $8 for a 2 surface filling, yet if it's a 3 surface or a 4 surface filling, there is no coverage at all. It's at zero copay. So it's very, very confusing, and the frustration comes, okay, you want to help this patient, but an average root canal costs you in time and money anywhere from $250 to $400 if you're using up-to-date systems. And that's what pretty much Medi-Cal pays for a molar root canal, but unfortunately they're not doing that anymore, and they're not going to be doing it in the future. So it doesn't make sense for me to open and med a tooth and then expose that to take out the nerve, leave a temporary in there, and I know it's going to fail in the future. And the tooth is going to be extracted. So it's just very confusing and very frustrating just trying to get through that. So the other alternative is just give medication, explain it to the patient, and obviously the patient's going to go, I don't have money to pay the root canal, so just pull it. And that's what we're forced to do. And unfortunately, I think one of the reports I read, one of the reasons Medi-Cal is coming back because of the tremendous amount of money they're paying to emergency rooms for the extractions, where a general dentist is doing it at the $38 copay or surgical $80 or whatever it is. But again, it's just ongoing and ongoing, and I know a lot of my colleagues are very, very frustrated that way. I personally know 10 people that just dropped Medi-Cal just because of that sense. Even though adult Medi-Cal is coming back, they go, okay, it's limited amount. But what am I going to do? Do a filling for $37? Because we just had another drop in 10%. It just, unfortunately, doesn't pay the bills. And 70 to 80% of an office is basically bills. So even if you're doing a tremendous amount of production, you're putting yourself through a tremendous amount of stress. There's no gratification in that sense. And I apologize, it's got a rude awakening with a lot of offices, either OBG or dental or medical. We all have a tremendous amount of finances and tremendous amount of bills we have to pay, and unfortunately that's not being met.
Mm-hmm. I think hopefully a lot of us in this room have something to say about what Medi-Cal Dental covers in the future. So I think that advocacy push is still ongoing, hopefully. So hopefully we'll see some improved coverage moving forward. We have time for one more question, and I think there was somebody right here. Yeah.
It's more of a comment. Again, my name's Katie Valderas. I'm with CPSP, and one of the barriers that we hear from our non-FQHC providers is that when they refer out to a dental provider, the clients are oftentimes feeling very pressured by dentists who upsell whitening services, braces, a lot of things that they simply can't afford. I mean, they're Denti-Cal clients. And it's hard because on one hand, they are businesses, and your point was right on point. You have staff to pay and lights to keep on and all of the insurance to pay for and everything, but it creates such a challenge for these patients who are just getting by to have to face this pressure to spend more money for their dental care. And these dental providers are making very hard to say no. So they set up payment plans and get the clients into debt and things like that. So I just wanted to point out that is another barrier that a lot of our clinics are reporting for the non-FQHC clinics.
If I can interject on that, you're pretty much looking at a lot of larger clinics. And a large number of larger clinics that have HMOs. Unfortunately, the whole HMO program has been disastrous. It's forced a lot of dentists into becoming salespeople. A lot of offices are failing because they're not practicing those. And I'm talking from personal experience. Now, we deal with Denti-Cal. We know it's unlawful not to sell to Denti-Cal patients, so that's a non-issue. But on the other side, unfortunately, these are forced upon dentists just to keep their doors open. And they're unscrupulous people. They're unscrupulous huge corporations that are making billions upon billions of dollars. But then again, that's only 20% side. So I don't know a single dentist that would sell braces to anybody that comes in under Denti-Cal, because even trying to practice under the Denti-Cal program as a single provider to become more of a facility that does corporation type of work, it's next to impossible to get the permission at this point. So, but there are clinics that do that, so you have to pick and choose your providers, and you have to basically take surveys to see what you feel comfortable with, if they've been forced into anything. It's there. It's a fact of life. Unfortunately, every single, either medical corporations, dental corporations, chiropractics, every single medical provider is going through that, and it's unfortunate that corporations have a hold on dentistry at this point. And those are the ones that are making the policy, and those are the ones that have all the power in the world to do what they want because they have the money.
Okay. Well, I think that's it for our panel today. We're going to move on to the rest of the program. Could I have a round of applause for our great panel?